Welcome to this episode of Left to Our Own Devices on Heart Rhythm TV, and I'm delighted this evening to welcome Nicholas Palmeri, who's an electrophysiologist on staff at South Denver Cardiology over there in Colorado. Good evening, Nick.
Hey, good evening. It's really nice to be on the show.
Thanks for joining us. The topic of discussion for this evening is management of vegetations during lead management and lead extraction procedures, of which I know you've got some significant experience, and I'm delighted that you're going to be able to share that with us this evening.
Sure, yeah.
Why don't we start by sort of considering when it's important to think about aspirating a vegetation during a lead management or lead extraction procedure?
Yeah. Yeah, I think aspiration is sort of this emerging technology. I should say I don't have an immense experience. I don't think that there's too many people who've done dozens of these types of procedures. It doesn't come up that often that you have a really large vegetation, more than a centimeter or 2 centimeters on a lead when you're getting ready to extract. But it's something that's important to think about because, if you're going to use any sort of energy to free up the lead, you're going to free up that vegetation, which then could embolize to the lungs. To some extent, it seems like that happens with extraction. I know there's been a couple studies looking at VQ scan. There's always some perfusion defect that happens after lead extraction due to, whether it's scar tissue or bits of vegetation that go to the lungs. But for some of these larger vegetations, I think that's really when you want to think about aspiration. Historically, a lot of the recommendations and some of the guidelines support considering an open surgical extraction in this type of situation. But a lot of the tools have evolved, and now there's a lot of novel therapies that are out there that make using a percutaneous aspiration safe and effective, and that might save a patient from needing an open surgical extraction.
That's great. What kind of what characteristics of vegetation make it large enough to be worried about in case of it embolizing distally? Are there specific sizes of vegetation or characteristics of the vegetation itself that would push you more towards an aspiration procedure?
Sure, yeah. I think the mobility of the vegetation on the leads always raises eyebrows. I think everyone's probably seen an example of a highly mobile vegetation, especially one that appears to be adherent to the leads or, emanating from the superior vena cava in one case that I can think of, or, on the tricuspid valve itself, in a place where you can access it. Uh, I can think of one situation where the vegetation was really sort of just thickening, manifested as thickening on the lead, where I didn't really think it was going to lend itself too well to using an aspiration tool in that particular situation. So a mobile, sometimes they almost look pedunculated, where there's sort of a stalk and they wave on TE or TTE. And I think that probably lends itself more to using a percutaneous aspiration strategy. In terms of size, I think I'd have to go back and look at the guidelines. I think 2 centimeters is considered a large vegetation for sure. In the 1 to 2 centimeter range, you sort of wonder about it. I did do an aspiration for a vegetation that was about 1.1, 1.2 centimeters. And when we actually got the vegetation in the receiver, we said, well, went to a lot of trouble for a pretty tiny, it looks huge on TE or TTE, but when it comes out of the receiver, you say, oh, it really wasn't so big. But yeah, I think that a vegetation greater than 1 centimeter bears some consideration, especially if there's multiple vegetations, especially if they're highly mobile, and certainly if it's greater than 2 centimeters.
Yeah, I think that's what we use here at University of Virginia. When they start to sort of get the size of being able to block off the pulmonary artery convincingly,
Exactly.
I think that's when we typically start to worry about them. And of course, like you say, if there's multiple, then it's that sort of vegetation burden that you worry about as well, isn't it? What sort of tools do you favor using in these cases?
Yeah. Well, so my experience is pretty much entirely with the AlphaVac system that's made by Angiodynamics. Um, actually, maybe now would be a reasonable time to show that. Let me just get the image queued up. Um, so let me share my screen here. So here we go. So this is the AlphaVac system. So it has a long cannula that is administered or introduced with a gore dry seal sheath, and it has an angulation at it with a funnel, and there's a dilator that you use to prop open that funnel, and it slides up through this sort of outer cannula, and it usually either has a cant or a curve to it that you introduce into the vein. So it has to come out kind of passively, since it is flared at the mouth. And then it has this, little hemostatic valve. So it has a receiver over here with a gripping tool that allows you to either pull 10 or 30 cc's of blood with each aspiration that you do. So it controls the amount of blood that you're actually aspirating. And then the contents of the receiver are then ejected through this sort of valve system where there's a one-way valve here and another one-way valve here, so that the contents in the blood go through this tubing into the bag, and that allows you to strain it for the aspirated material, the vegetations, and also you can save that blood by introducing it through a cell saver if there's sufficient blood accumulation in the bag. This is in contrast to the AngioVac system made by the same company, by AngioDynamics, whereas the AngioVac requires continuous blood flow and does require perfusion. This one's a little bit friendlier to the electrophysiologist who may not have the availability or control over perfusion, staffing and things like that. So this is a really it's a great instrument for aspirating the types of vegetations that I've had the opportunity to go after, which are in the right atrium. Sometimes the reach might be a consideration, getting across the tricuspid valve that we were talking about if you had a vegetation that looked more towards the right ventricle. But the ones that I've seen end up being in sort of the atrial component of the lead anyway, and so are readily accessible by this device. And you can sort of straighten the angle of the funnel, the aspiration sort of site, the flare here, by withdrawing the inner cannula into this outer cannula. And so that way you can adjust the angle of the device as you're getting ready to aspirate.
Is the shaft of that deflectable, or it's just got that angulation to the tip of it?
Yeah, just an intrinsic angulation. So that's maybe one limitation of the device, but with being able to adjust the depth of the cannula, and then as well as the angulation and the rotation, you end up getting 3-4 degrees of freedom on the device so that you can aspirate effectively.
Absolutely. And so you don't need a perfusionist for that, or a cardiac surgeon to be in the room. You're in control of the whole thing.
That's right. Yeah, it helps to have a couple of hands, but yeah, that's the big advantage, I think, is then you're not relying on perfusion or somebody with cardiac surgical expertise. You don't need a second cannula. So in the cases where I've done this, I use the gore dry seal, do the aspiration first, and then leave the dry seal in, and then put the bridge balloon through that up into the superior vena cava, and then prepare to do the I use laser for my extractions. Yeah, so it ends up being a pretty easy workflow. You don't need access in the neck or bifemoral access if you have a temporary pacing wire on the contralateral side or something like that.
Excellent. And when you're targeting the vegetation with that particular technique, what kind of imaging do you use? Are you using TE for that? Are you using ICE? What?
Yeah. We use TE at our institution. It's very easy to get a cardiac anesthesiologist to help out. At other institutions, that might not be the case, but at least in my practice, it's very easy for us to get the cardiac anesthesiologists. They like using their TE skills. They are good at imaging. A lot of the imagers are really quite talented. And I'll show some images where we can actually see the cannula and that flared cannula live, which was really helpful. So then I've got someone who's steering TE, and I can really focus on doing the aspiration and manipulating the catheter to get it just so. But yeah, I think that ICE would be great for these. You could see it, and then if you're working with a fellow and one of you is manipulating the aspiration cannula and another one is manipulating the ICE, then you can do it together. And to be honest with you, the aspiration cannula even it's helpful to have an extra set of hands there to do the actual aspiration part in addition to the cannula manipulation.
Absolutely. You mentioned that you've got a case or two to show us. Maybe now would be a great time to take a look at that together.
Sure. Yeah. Let me just get this set up. This was a woman in her 50s who had a history of melanoma and a non-ischemic cardiomyopathy. She was on some sort of targeted therapy, and that may have played a role. But she ended up getting a CRTD about 5 years before I met her. She ended up coming to our hospital with sepsis, was in septic shock initially, and ended up having Group B strep blood cultures that were positive, repeatedly positive, despite antibiotic therapy. So this was the original image of her device. So, you know, maybe some redundant slack here in the RV. I'll say again, this was implanted at a different institution. But we got a TTE that revealed a vegetation and ended up doing a dedicated TEE here that showed this vegetation, this pretty mobile vegetation here, which looks like it's probably on the RV lead. Just it's always hard, you know, to tell on some of these. Here's another image. And there you can see it was kind of more sizable. You can see it coming in here. It was up to 4 centimeters on some of the images. There you can see it kind of in a long axis, and this is sort of hanging off or attached to this was sort of the best shot that we had in the preoperative TEE. The TT images weren't showing, but there was some evidence of the vegetation on the TTE as well. So we ended up planning to do this case with the AlphaVax system, since that was one that I was familiar with. We did this about 9 months ago. I think it was in May or June of last year. And here, just to orient, you know, so we have our TE image, and this is actually, you'll be able to see the flare of the intake cannula up here. The catheter is sort of coming up along the septal side of the right atrium, and we're aiming it sort of over here towards this vegetation first, and then taking down this vegetation. So here's this live image on TEE. So there you can kind of see the flare of the device, and here's that vegetation that we're trying to deflect towards. And you can see it starting to come here. This is the same video, just played again. And you can see there's this vegetation here. This might have been after we had aspirated 1 or 2 from the leads. And this is another sort of image where you could see the vegetation being debulked. Our cannula is up in this direction now. Let me see if this one will play. Here's the flare of the device here, of the aspiration device. Still a little bit of residual vegetation there. You know, these are some of the clips that our anesthesiologist is taking, while we're doing the actual maneuver. You're trying to have the wherewithal to say, "Oh, record that," as we get it. But this is what we ended up aspirating from the leads that came out into the receiver. So a couple big chunks. There were multiple pieces afterwards. This one ends up measuring up to almost 6 centimeters. Of course, it was probably bunched up. You can see there was sort of this slimy outer layer, whereas inside it's maybe a little bit more complicated. And then we end up doing the laser. This was the only, I was saying to Oliver as well, that I always regret not fluoro storing all of my images from the actual laser, but there goes the rest of the system here. And then this is what the leads, what the right atrium looked like after we had done our aspiration and after extracting the leads. You can see there might be some residual, something tiny over here, but compared to what we had before is pretty significant. And then no real tricuspid valve vegetation on there as either. We always wonder, what are we going to get from the cultures? And then this is from both the pocket, which we weren't surprised. The pocket did not look to be infected. It was really just this bloodstream infection. And I was surprised that we didn't get anything from the cardiac tissue, perhaps because she ended up getting about 3 or 4 days of antibiotics before we ended up doing the aspiration. But I still think that we probably served her by not sending all of that material into the the pulmonary arterial tree.
Yeah, remarkable result. Really, really impressive. You know what I hear some people say that it's so challenging to aspirate these vegetations, and by the time you've tried, you've knocked most of the vegetation downstream. You know, what would you say to those people, you know, especially now that we've got these easier to use tools that are, you know, in our control?
Yeah, I think whenever you're doing a lead extraction procedure, you're going to knock, like we said at the beginning, the VQ scans show consistently that there's always a little bit of a perfusion defect after you do a lead extraction. I think it's inevitable to some extent, but again, if you can minimize these really large vegetations, I do think that you serve the patient compared to sending something that's really large like that to the pulmonary artery, or having the patient go for an open heart surgery where they're going to be performing a right atriotomy, at a minimum, and perhaps, doing just more advanced exploration than what we could do minimally invasively. So I do think that one thing that's nice about this system is that receiver allows you to look and see, okay, did we actually get something here when you filter it? And so seeing those results, I think, is really satisfying.
Do you immediately get feedback in the chamber of the device that you know, when you aspirate and then you flush the blood through the filter? You're presumably you're immediately seeing that you're aspirating vegetation material, right?
Yeah, it ended up guiding us in terms of deciding whether or not we were going to go for that other little bit that was hanging on, because we had gotten so much, we had debulked, the vegetation burden enough. We said, well, I don't think we should go after that other one that was sort of on the right atrial free wall that you saw flapping over there. In the actual receiver on the AlphaVac, sometimes you can see if it's a very large vegetation, you can see, and it's often white, you can see it up against the transparent canister. But sometimes if there's a lot of blood in there, you can't see it very well, and it's only after you filter it that you see it. But yeah, you can see it right then and there. You do the filter live. It's really cool.
And how much blood did you take out to get that much vegetation in that particular case? And did you reinfuse that blood, you know, as a part of the sort of setup?
Yeah, I believe in that case we did 5 to 6 pulls at about 30 cc's a pull. So that to get that vegetation, we only ended up losing about 150 to 180 cc's of blood. And there's also sort of these you can do smaller pulls, like 10 cc pulls, because if you get a vegetation that ends up occluding the mouth of the cannula, you can continue to apply negative pressure until it ends up getting aspirated down there. So you can use some of these smaller pulls as well. But yeah, it was only about 150 to 180 cc's of blood, and I said, great, let's send it back in, and we did end up getting a perfusion team there. They said it's not worth putting it through the whole cell saver. The volume was so small. So yeah, so it ends up being a way to control your blood loss when you're doing these aspiration procedures. So.
Absolutely. You referred to surgery as historically being an option for large vegetations. Do you think there are still cases where we should involve our cardiac surgical colleagues rather than trying these percutaneous aspiration techniques that we're in control of?
Certainly, yeah. I think it's whenever you're dealing with a transvenous lead infection, it's about a multimodality, multidisciplinary discussion about what's the right thing for the patient. I didn't show the T images in this particular case that exonerated the mitral valve and the aortic valve. If you have someone who has surgical valve disease, then it's a totally different discussion. They're already probably buying themselves a sternotomy and valve surgery. So in those circumstances, then sometimes maybe debulking could be beneficial. It's still worth a conversation, but it depends a little bit on the urgency of the surgery. If you're having embolic disease or a very large vegetation or heart block, some of these classic indications for surgical intervention, then maybe it's best to just let the surgeons do their job, and then not do the aspiration. In my experience, though, most of the time the cardiac surgeons appreciate having the device out before they get in there. It depends on the practice patterns. There's some places where the surgeons are doing the laser lead extraction. There are other places where it's more EP driven. At the institutions where I've been, it's laser lead extraction was more EP driven, and then the surgeons would say, "Thank you for clearing that out," and then they'll go and do their part next. So it's really just involves great communication with all the different specialists, communication with the infectious disease doctors, of course, and imaging experts in addition to cardiac surgery.
Yeah, for those surgical cases, we really want to try to avoid that dreaded eventuality where patient goes for surgery with the intention to extract the device surgically, not with a laser or mechanical rotational tool, familiar surgical approach, and we end up with a cut lead which is adhered from the SVCRA junction all the way back up to the pocket, and no great options for extracting those leads once they've been cut, especially if they've been cut like I've seen several times at both ends, but from the pocket and at the SVCRA junction. We really want to avoid that at all costs. So like you say, getting our hands on these patients initially before the surgical procedure seems oftentimes to be the optimal way to avoid that particular scenario, doesn't it, I think?
Absolutely. And I think early appreciation of infection is key. Um, uh, there's been a move towards having alerts through the online medical record to make sure that an electrophysiologist gets involved early for these types of decisions. I'm sure you know the type of situation where someone's been on 5, 6 antibiotic regimens, before you end up getting called to take out the device, and then it's always a little bit tougher to make decisions in that situation.
Well, I'm glad you brought that up. So EMR alerting is something that's in action in South Denver. In your group, is it, or?
It's emerging. It's not quite there yet, but yes, we're getting there. We're working on that. I think in part because I started at sort of we didn't have laser lead extraction that was EP driven before I started our program, and so at first we wanted to make sure that we had a nice safety track record, for a year before we started to get more aggressive. But looking back over the past year, in about 30 extraction cases, the vast majority were for lead related complications. Whereas, as you know, nationwide and worldwide, the number one indication for lead extraction is infection. And so it's made us appreciate that there are a lot of infections that are getting missed or under recognized, or as I've found out, are being managed without lead extraction when in cases that I think it probably would be more optimal for them to get an early extraction according to copious data at this point.
Absolutely. That's a really important point to finish on, I think. Nick, thanks a lot for joining us this evening. It's been a lot of fun. I should say that, depending on the institution where you work, there are multiple different kinds of manual aspiration tools like the one that we've discussed this evening, including the Inari Flowtriever or the Penumbra system. And, oftentimes it's worth reaching out to your pulmonologists or people who aspirate things like
Sure.
PEs, to try to figure out which one of these systems you have at your institution, because they're all useful in a similar way to which you extremely elegantly showed. So thanks for joining us this evening. It's been a lot of fun, and hopefully see you at HRS.